Hello, and welcome to the third session in the Alliance's 2020 Signature Series Summit on Disruptors and Transformers. This session is titled Care Delivery Transformation, Integrating Telehealth and Home-Based Care. I'm Catherine Martucci, Director of Policy and Programs for the Alliance for Health Policy. Listeners who are new to the Alliance, welcome. We are a nonpartisan resource for the health policy community dedicated to advancing knowledge and understanding of health policy issues. And the goal of this multi-part virtual summit is to explore the short and long-term impacts of the ongoing COVID-19 pandemic and its potential to significantly transform our healthcare system. We want this to be an interactive discussion, so please get your questions ready. You should see a form on the right side of your web browser that is labeled Submit a Question. You can send in as many questions as you would like at any time, and we'll be collecting these and addressing them throughout the broadcast. You can also find all the materials that accompany this session on your Summit interface and on our website. And a recording of this webinar will be available on that website soon. If you're having any technical issues during the event, please click on Troubleshooting Tips and Technical Support, which is in the bottom left-hand corner of your screen, and someone will help you. And then finally, please take the time to complete the brief evaluation survey that you'll receive via email later today. We really appreciate your feedback. Join us throughout the week on social media by using the hashtag AHPSummit20. And please feel free to ask questions and engage with us and each other after sessions end as we continue the conversation online. And then please join us later this afternoon at 2 p.m. Eastern for an Executive Insights interview with Jenny Bryant. And we also have sessions on Thursday as well. And so now I'm so happy to introduce to you our guest moderator, Anand Parikh, Chief Medical Advisor to the Bipartisan Policy Center, where he provides clinical and public health expertise. Dr. Parikh is a board-certified internal medicine physician, a fellow of the American College of Physicians, and an adjunct professor at both the University of Michigan and Johns Hopkins University. Before joining BPC, Dr. Parikh served with the U.S. Department of Health and Human Services for 7 years, and at one point was the Deputy Assistant Secretary for Health, where he developed and led initiatives on prevention, wellness, and care management. And earlier in his career, he played key roles in national public health emergency preparedness efforts on influenza and bioterrorism. So with such a prestigious background, we are very pleased to have him with us today to lead and moderate a panel discussion on care delivery transformation in the era of COVID. His full biography is available on our website, and I encourage you to look through it along with the biographies of our other prestigious panelists today. And so thank you again, Dr. Parikh, for joining us, and I'm pleased to turn it over to you.
Catherine, thanks so much for that introduction. It's truly an honor to be with all of you today. I want to congratulate the Alliance for Health Policy on their summit. I'm really excited about this panel discussion on care delivery transformation. I think, as most of you know, care delivery in this country has been transforming for some time now. And certainly given COVID-19, there have been advances. Today, we're going to be talking about two specific sectors, the telehealth sector, as well as the home healthcare sector, to better understand where we've been, how COVID-19 is transforming these sectors, and what that portends for the future. Now, I think when we think about complex patients in this country and individuals with multiple chronic conditions, I think this topic is just so important because this is the population often experiencing health disparities, high preventable healthcare costs, and poor health outcomes. And I think several strategies that have been elevated to help this population include sort of high touch and high tech strategies. And I think today we're going to be talking about how best high tech and high touch strategies complement one another, how we can balance them, again, to improve health outcomes and reduce preventable healthcare costs for the nation. We're really pleased that we have four outstanding speakers, guest panelists who have joined us today, and I think you have their biographies in the handout section, so please review them. I will briefly introduce them. We have first Nancy Green. Nancy is the president of the SAA Group and lead on the American Telemedicine Association's Aging Friendly Special Interest Group. Welcome, Nancy. We also have Jeff Nudd. Jeff is the CEO and founder of ClearCare. ClearCare is an innovative technology company with a platform that is used by thousands, really, of home healthcare agencies across the country. Thrilled that Jeff has been able to join us. We also have Mike Whitkey. Mike is the Senior Director of Public Policy and Advocacy for the National Alliance for Caregiving. And we're thrilled that Mike is with us. And then we also have Dorothy Seaman, who is the Senior Vice President of the Office of Policy Development and Integration at AARP. And we're thrilled Dorothy can also provide us with the important patient voice. So we have four great panelists, different perspectives. And I think to start off, what I'd like to do is ask all four of you, and Nancy, we can start with you. If you can provide sort of a couple minutes summary to the audience here about how COVID-19 has impacted either your organization, the stakeholders you represent, stakeholders more broadly, as well as, I think, the telehealth sector.
Yes.
Nancy?
Yeah, absolutely. Thank you so much. So as Anand said, my name is Nancy Green, and I'm with a consulting firm that's focused specifically on helping organizations accelerate in this space. So digital health and telemedicine. And I am here today representing the American Telemedicine Association, which most of you know, but it's the premier organization working to accelerate this adoption of health. So what's changed? So much. I have so many stats, and just making sure that I had some of the latest stats. I'm going to take it from a kind of a macro level, and the other panelists will get kind of further into it. So some of the major pieces that have happened. So if you look at telehealth among Medicare beneficiaries, it's up over 11,000% in the last couple months. The VA has had an increase in 1,000% in their telehealth video appointments, as well as hundreds of thousands of additional prescriptions, refills, and secure email exchanges during this time, which is just phenomenal. And there's research and stats on that patients actually like it. The usage is up, and consumers are saying that they will continue to use it. In the children's space, Children's Health here in Texas, I'm in Dallas. This is one organization that needed to pivot, and so they took their 53 clinics and completely moved them to virtual appointments. So they went from their clinics down to up to 16,000 virtual visits during this time. And one of the largest systems partners, which is now called Mass General Brigham, these were staggering numbers. In their pre-COVID, they averaged about 1,500 virtual visits in their ambulatory outpatient area, which was like 0.2%. Post-COVID, it's went from 1,500 to over 250,000 a month, and it's now 60% of all their ambulatory is done through telehealth. And I have lots and lots of these stats, but 10, 20, 30-fold in organizations that had to pivot quickly to be able to, from zero, this was NYU Langone, went from 0 to 5,500 visits in a day. So huge numbers, and just a recent Forrester report that it's on pace to top 1 billion by this year's end. So lots of numbers, lots of stats. And I know some of the other panelists have very specific ones in their particular area. So that's the 10,000 foot level. I could keep going there. It's just amazing numbers.
Great. Nancy, thanks so much. Jeff, do you want to provide a perspective from the home healthcare industry, your organization, and stakeholders?
Yeah, sure. So again, Jeff Nudd, CEO of ClearCare, part of the WellSky family of companies. By way of background, we provide, as Dr. Parekh alluded to, the core technology, operating technology, and clinical technology used by over 15,000 home and community-based providers. So over 4,000 personal care agencies are staffing over 600,000 caregivers, helping with ADLs and social determinants. Over 3,500 home health agencies use our platforms all day, every day. 70% of the home infusion market providers use our platforms. Over 50% of the area agencies on aging, and we manage over half the homeless population on our platform. So really broad footprint, and gives us a unique purview to how COVID affected home and community-based providers and care. And I'd summarize it as almost a tide going out and then a tide rushing back in again. And in the initial weeks, safety, of course, drove a lot of very dramatic change. So across home health and personal care, those sectors in particular, census dropped within about a month, between 15 and 20%, around risk and concerns from both the employees, the nurses, and the caregivers going out into the homes, but additionally from the patients. PPE was and training were a huge concern in the home and community-based sectors, as they were and are in so many sectors of healthcare. But that's rebounded and then some. And the reason, of course, is home and community-based care is a substitute for facility-based care, and so as concerns about infection risk in facilities have become more prevalent, conversely, as the PPE challenge has been solved for home and or largely addressed for the home and community-based providers. More and more care then is shifting back to the home and community and away from acute care settings and senior living and other facility-based care. Similarly, even in home infusion, we're seeing increases in census and visits, driven by the desire for patients to stay away from facilities that are viewed as higher risk. And in many ways, COVID has acted as a catalyst what's been a broader long-term shift of care out of acute settings and facilities to the home and community, driven by long-term trends, impact of social determinants, impact of functional limitations, these factors that we know drive so much cost and utilization and outcomes for patient populations. Part of a long-term macro trend and shift to the home community has just really been accelerated by COVID as a catalyst.
Great. Thank you, Jeff. Mike?
Yeah, hi. Thanks for having me on today to speak a little bit about how family caregivers fit into the transformations taking place in care delivery, especially now. Just a little bit about our organization. We've been around for over 20 years doing research and advocacy on behalf of caregivers. We're located in DC, so we do a lot of work with members of Congress and their staff, different policy experts, researchers, and even stakeholders in the private sector. Something we've been following for a while. A lot of the work that we do around caregivers and what we know about this population of people who are family members caring for those with serious conditions come out of a research report we do in partnership with AARP called Caregiving in the U.S. We actually just released our most recent report. We were not planning to have this coincide with recent changes in our healthcare system, but it just so happens we do this report every 5 years, and it's something that is helping the healthcare sector in general understand how many caregivers are in the country, what they're doing, and how we could be supporting them. One of the most striking facts about this population that we know already was that they provide an economic value of approximately $470 billion. But this value comes at a cost. Caregivers have the situation of caregiving puts caregivers at risk for their health and their well-being being deteriorated. Their financial security is at risk, and even as we move into the future with more people working, there are less caregivers actually available for those who are going to be needing care into the future. The history of this landscape is really actually kind of new. The first federal program was established in the early 2000s. So, on a national level, we're really kind of just wrapping our head around how to understand who caregivers are, how they fit into the larger healthcare ecosystem. Oftentimes, caregivers don't self-identify, and it's really up to those who are running systems and those who are sort of within the healthcare delivery ecosystem to be able to identify who caregivers are, to be able to draw them out and actually bring them into the care team in a way that's going to be more effective. And COVID-19 is just speeding that up. There has been some investment in federal programs that we can learn from. There's been some work. There's a national program through the Aging Network, mostly administered through area agencies on aging. There is a VA caregiver program on the federal level that provides military and veteran caregivers with services, which was just expanded, and we can learn a lot about how those services have worked and what can be done to expand some of the efforts that have been done there into other sectors of the healthcare system. And we've also learned a lot about what's been happening around the globe. Caregivers are not just unique to the United States, and we know that other cultures have actually been able to adapt families into the healthcare system a little bit better. Another thing that really kind of is drawn out here is how we look at the relationship between caregivers and the direct care workforce. Actual professional caregivers, those who are home health providers, who home health aides, things like that. We need to think creatively about how caregivers can be better incorporated into situations where direct care options are insufficient, but we need to make sure that we're not relying on them so heavily that we're thinking of them as a replacement for paid professionals. The impact on COVID-19 specifically really is exposing existing vulnerabilities that are within the healthcare system that families already face. It's really an explosion on top of an already volatile situation. So the way that things have changed for caregivers as a result of COVID-19 looks two different ways. There are those who are caring for people in the home. They are a lot more isolated than they ever have been before. And then there are those who are caring for people who actually live in facilities. And there's been a big disruption in the continuity of care where families have not been able to go into these situations. Actually, in some of the bills that were passed to provide some relief, caregivers were not included in some of the paid leave provisions as they should have been. So it's another thing we're looking at. So those are some of my opening remarks, and I'm happy to talk a little bit more.
Mike, thank you so much. Dorothy?
I'm happy to be here. My name is Dorothy Simon. I am the head of policy development and integration at AARP. And AARP, for all of you, is the largest nonprofit representing 38 million members. So what we try to do as an organization is really bring the voice of those 38 million members and caregivers. And we've been very active in the caregiving scene. So you're going to hear me echo our agenda in terms of caregivers in this. But to answer your question, what has the shift been? Someone else said that COVID has been a catalyst to shift to home-based care, and that is significant. And others have alluded to the large numbers and the changes that have come from that. The other piece that I want to draw out here as well is the isolation piece. And really, as COVID has really changed how people can access care, and telehealth has been critical in getting people access to the care, it also has created different levels of isolation. And that's a big, big concern for us in terms of in the home as well as in facilities. So I want to highlight that in terms of a major priority for AARP is trying to change the reality in nursing homes right now for nursing home residents who are very isolated. What it illustrates is that access to care means access to quality of life as well. If you don't see your loved ones, that has an enormous impact on your health. And so that virtual visitation is something very, very critical. And I think that getting across changing what isolation looks like and intending to eliminate or mitigate it, whether an older person or a person in need of care is in a nursing home or in their home, is just so critical as we go forward. So that will be a major priority for us. AARP's agenda on telehealth has been long-standing. We've been active in the states across this country to try and really expand the access, and we've done a lot of polling. This acceleration of its use, we're trying to understand better, and we've done some recent polling, and there really is increased interest among older people in telehealth and what it can bring to them. Obviously, there's a need driving that, but those numbers have climbed, and it's a little more than half. About 80% would identify that they would use telehealth services to get help with caregiving, to have a routine visit. So these are kind of numbers climbing for the kinds of things people are open to. But the other piece that the polling reveals is there's also remains a lot of challenges to access, and whether people have the equipment, whether they have broadband to access internet. So you'll hear our agenda is focusing very much also on that, and how do you get access to broadband for people to allow them to use these kinds of services. And the final thing I'll say is we continue to want to bring the voice of caregivers into the delivery of care. And I'm echoing some of Mike's comments that as telehealth has rolled out, it's really important to continue to bring the caregiver voice and to have family caregivers even more integrated into that. And I think telehealth has the promise to do that. It can really help caregivers have much less of a burden in terms of getting people to appointments and doing those things. So we're really looking at the promise of what telehealth can do to really help caregivers as well as the people they care for. So I'll stop there. I think some of this is all interrelated, and we'll get to it as we continue this conversation.
That sounds great, Dorothy. Well, thanks to all four of you for providing a framing for this discussion. And perhaps I'll follow up with a question to each of you based on your opening comments. And Nancy, maybe we'll start with you. I think the question essentially is, what are some of the policy changes that you all are seeing and are needed looking to the future? And I think, Nancy, with respect to telehealth and telemedicine, certainly there have been both regulatory as well as payment modifications, temporary in some cases at the federal level, as well as now at the state level. And if you can just summarize for the audience what some of the key changes have been, and then from your perspective, what are those temporary changes that really need to be made permanent to ensure that telehealth and telemedicine can continue to serve the public in an efficient way and improve health outcomes?
Yeah, thank you. And Dorothy, I remember actually one of your stats that I used in a webinar that I was just doing, that isolation and loneliness is the equivalent on your health of 15 cigarettes a day. I was just shocked by that. So I'm excited that some of this technology can help with that. So I'll take what we've just done recently where the ATA supported some new legislation that was introduced to the House by the bipartisan House Telehealth Caucus champions, and that was to permanently expand the use of telehealth post-COVID. And it's supported by over 340 stakeholders, but it's specifically focused on removing geographic restrictions and allowing the patient's home to be an originating site, enabling and enhancing the HHS authority to determine the right services, enabling and ensuring federally qualified health centers and rural health clinics can continue to furnish telehealth, and to make permanent HHS's temporary waiver authority for future emergencies. And I think it's so important to point out, and Anya just kind of said it, was that you can't just shut these off. All the services that have been there now. So the geographic, if we point out the geographic restrictions, the location of where the patient is receiving care or where their provider is, they should be able to receive it anywhere on any device. The standard of care should be the same as if they were in person, and it shouldn't be limited to a specific provider type either. So non-physician providers should be included. And in the underserved and at-risk populations, and both of that's rural, even underserved in urban communities, tribal nations, and the uninsured. I know we're going to talk about this, but the state and federal programs really have to work towards robust investment in telehealth. The infrastructure side that includes broadband to enable that universal access. And close to my heart is the senior population, and we need to make sure that technologies and access to those cares, affordable access to the care, to be able to age friendly in whatever environment that you want to. And I think it was Mike that said privacy and security. So that has to be added to that. We need to make sure that we can help and mitigate any kind of cybersecurity risk in patient security and confidentiality.
Great, Nancy, and one follow-up question. I'm wondering if you agree, do you see this also as sort of an opportunity for the health service research community as telehealth expands? We're going to have more and more data as to the ability of telehealth, again, to potentially improve health outcomes and reduce preventable healthcare costs. And it seems like as we make these changes, we ought to be measuring these and doing the research to support the policy changes that are necessary.
Absolutely, and I thank you, because I do think there's research going on now, and I think some of the research is just coming out. I think data and the analytics of the information will be key in helping support this going forward.
Great, great. Jeff, you used the word catalyst. I think several of the panel members caught on to that as well with respect to home care. Can you talk a little bit more about, again, how COVID-19 is that catalyst, and what are some of the perhaps policy or programmatic changes, Jeff, to really push home health forward to support patients who need those services?
Yeah, sure. So, really the growing evidence base is what supports the long-term shift to home and community-based care. And just to share some numbers, WellSky and Avalier partnered with some research to understand the impact of non-medical home care interventions on aging population 65 and older with multiple chronic conditions. And for that population showed a $530 PMPM lower cost for a home care intervention population versus the control population. And even greater differences in cost when applied to patient populations with an overlay of functional limitations or things like fall risk, vis-a-vis, along with multiple chronic conditions versus the control. And those savings due to, this is non-medical home-based care, I think are in many ways no surprise. We know that functional limitations drive a 3x multiplier of cost for a multi-chronic population with functional limitations, the 3x multiplier of cost. And when you look at the top 5% of patients that drive 50% of healthcare costs in the United States, over half of them don't just have chronic conditions, but also functional limitations. And functional limitations are long-term in nature. They impact healthcare in the home and community, not in clinical settings. And the intervention strategies to mitigate the impact of functional limitations are non-medical in nature. And yet, if we look at the reimbursement landscape for the kind of intervention strategies that can mitigate the impact of functional limitations and social determinants, it's a highly fragmented reimbursement landscape. When you look at the kind of long-term in-home care reimbursement landscape, it's almost entirely fee-for-service, and it's state by state, driven largely by Medicaid, with other payers as well. But Medicaid accounts for most of reimbursement. And in fact, what it does is it creates a sort of a barbell access scenario wherein the Medicaid population can get access to this kind of care. The people that are wealthy enough to afford it out of pocket can get access to the kind of care that can mitigate the impact of functional limitations. The income classes in the middle are not able to access it. And yet we know from the data that this kind of care doesn't just help avoid facility care. It's not just better for quality of life. Staying in home is of course what patients want, where 90% of patients want to age in place, is the AARP is published based on their research. But this kind of care to mitigate the impact of functional limitations in a value-based construct acts as a lower cost substitute for acute care. And in fact, when you run the numbers on the impact of functional limitations nationally, given that they drive a 3x multiplier in cost for the population that has functional limitations, specifically attributable to that, given the fact that over half of the population accounting for 25% of all healthcare costs in the U.S. has functional limitations, that number approaches $800 billion per year by 2026, specifically attributable to functional limitations. And yet we have a highly fragmented fee-for-service reimbursement landscape for mitigating interventions. And so what the data calls for in a broader sense beyond COVID is a national reimbursement framework and a value-based care reimbursement framework to support the kind of integrated interventions, non-medical personal care, integrated with telehealth and coordinated care models to impact these costs and improve outcomes. I think you could argue it's single largest opportunity in the healthcare system in the United States, is to create the right reimbursement framework to support the interventions and go after these non-medical factors.
Jeff, thanks so much for your comments, particularly I think as we move from fee-for-service to value-based payments and value-based healthcare transformation, and really positioning home health in that scheme, I think is really, really important, I think, for the future. So appreciate those comments. Mike, if we can follow up on your initial remarks, and you started to allude to this about how we need to better support caregivers in our country. If you want to tease out a little bit more the differences between the professional caregiver workforce and sort of the unpaid family caregivers, and if you might talk a little bit more about how we can best integrate caregivers into the healthcare delivery team.
Yeah, thank you. So I want to just I'll point to a federal advisory council that's taking place right now. Not too long ago, there was a bill passed called the Raise Family Caregivers Act, and it created an advisory council that's supposed to come up with a national strategy to help us learn how to support caregivers across the country. And the reason why I point to this is because that's really kind of how far we are as a culture at really understanding how families fit into this larger healthcare ecosystem. We're at a point where we're just trying to define how that looks on a national level. So, you know, there needs to be much more, you know, emphasis on the work that comes out of that council. We need to make sure that the work that they're doing does not just sort of disappear, and that there is some sort of mechanism that drives, you know, the discussion forward. They're not going to reinvent the wheel. There's a lot of recommendations that are already out there. You know, this is a field that's been developing for the past 20 years. And the next step is really understanding implementation, how you actually bring these services to bear. We learn a lot from what happens within the aging population specifically, because there are a lot of caregivers caring for, you know, older parents, those with Alzheimer's and things like that. The number one thing that we are trying to do to make sure that we are understanding how to bring them into the care team is to do some sort of assessment, some sort of formal assessment where we actually turn to the caregiver and say, all right, what are your strengths and weaknesses here? What is it that we can be referring, what types of services can we be referring you to not only be able to provide the care that you need to do, whether it's medical or nursing tasks and things like that other professionals would likely be doing, or whether it's to actually maintain the caregiver's own health and well-being, whether that means getting access to respite care, getting a chance to maybe actually have the ability to cover the services that would be required for direct care workers. That's an expensive cost, and there's a very small the field. The demand of direct care workforce, providers who are out there is very small compared to the need. So, you know, there's just a big push to try and make sure that we're getting better quality care workers out there, that they are able to be in the types of geographic regions that caregivers are. You know, caregivers are all across the country. If there's much more likelihood that they're going to be able to be able to access services if they're in an urban area versus a rural area. So there's the direct care workforce in and of itself is it's almost a separate conversation from family caregivers, because they have their own set of needs and there's so much that needs to be done there. But really what is going to be the balance to walk there is to understand how that relationship looks. I mean, really, we're trying to define that as we're moving forward right now.
Great, Mike. Thank you so much. Dorothy, would you like to add to that, particularly from the caregiver perspective? And I think you very importantly brought up the importance of social isolation and loneliness as independent risk factors of mortality, particularly for older adults. And how do we ensure we're supporting older adults and the role of caregivers and how we support caregivers as well?
I was muted, sorry. AARP has had a very active agenda for some time around family caregivers. And I echo Mike's point that, there's just a lot of need there in terms of supporting caregivers in things like having employers recognize that people need to take time off to do that, or flexible scheduling to allow that, a whole range of looking at supports from the employer side of how you support family caregivers to continue to do the critically important stuff they do. Additionally, on the care side, integrating family caregivers into the care plans and into people's care as they are being discharged from hospitals, for example. And AARP has worked throughout the states on trying to get something called the CARE Act passed, which is passed in many states already, which really does acknowledge the role of caregivers and the importance of really having that good discharge planning and the integration of caregivers into that planning. So there's more to be done, certainly, and the interesting and kind of exciting approach of telehealth is really looking at how this care delivery system can really help caregivers as well as the patient. And I think there's a lot of promise there that we can talk about in terms of family caregivers. It could really decrease their burden. And if they are right there in the telehealth visit, that could really have such an integration effect where they don't have to worry about getting off of work. Or if they live somewhere else, you could be brought into that visit through a telehealth mechanism. So you have these offsite caregiving, family caregivers who may not be the daily family caregiver, but they're really important in the decision making, and they could have that continuity. So we see some really important benefits of telehealth, particularly with this broader access of the site of origin, and having people really have access to mental health services as well. And that gets to the isolation point, because I do think isolation cuts across both the person receiving care as well as caregivers. And so the ability to access that kind of care, telehealth has really revolutionized, and that may be just something going forward that has really positive impact that we want to look at and see what is it people are using, what are they open to, how do they do this. All of this becomes dependent, as I said, on broadband and these underlying supports and investments that are needed to make sure this access is available to people across the board.
Dorothy, that sounds great. Thank you for those comments. It actually leads me to my next round of questions. We'll do one more round, and then I already see a number of audience questions, which we definitely do want to get to. So this round of questions really focuses on teeing off Dorothy's comments on equity. And the question is how do we ensure these technologies, these services, telehealth, home care, how do we make sure that all Americans are able to access these, and particularly those who are most vulnerable to poor health outcomes? How do we make sure that some of the barriers, whether it's cost, whether it's broadband, how do we address some of these barriers? So if each of you can comment on how do we build equity into our programs and policies moving forward, I think that'd be terrific. Nancy, do you want to start?
Sure, I'll start. And I think it's been said, but to really effectively leverage and expand telehealth, digital health, virtual care, however we want to state that, I think it's so important that at the federal and state health policy level, that technology and modality and the site needs to be neutral. They have to have access to be able to access the data. I think Dorothy just brought it up. Broadband is a big piece of it. And that's a lot of state and local work that needs to be done in those particular areas. And coming to terms really with how the care has been reimagined and being able to still offer those services in a fair and equitable manner is so important in what we need to do going forward.
Great. Jeff?
Yeah, I'll just, of course, telehealth ultimately is a model for expanded access and means of putting the, for all communities, and provides means to put the world's clinicians at the fingertips of anyone with a smartphone or internet access. When supplemented with tools and devices such as Tidal Health and these systems that are coming out to help a remote physician collect information, they become even more powerful and expand the scope of what telemedicine can do. We advocate for, I think Nancy's points on neutrality around reimbursement are precisely on point. And I'll reiterate the importance of the shift to value-based care models, ones that enable integration of truly coordinated care models focused on disease states that combine telehealth, home care, and home-based care to achieve outcomes. Some of the gaps that we see are when the demand is for highly coordinated care that combines these, that operates across settings in order to achieve a given outcome. And so by way of example, Geisinger rolled out a very successful program for high-risk diabetes patients. So A1C greater than 8, 2 recent hospitalizations, so precise targeting criteria. But the intervention calls for not just telehealth, but also help with nutrition training, access to healthy food, in some cases, in-home care visits. Highly effective intervention reduces costs from over $100,000 for this specific patient population to less than $35,000 over a 12-month period. And that can fund this intervention, generate savings for the system, generate better outcomes for the patient. But the reimbursement mechanism for that is highly fragmented. So creating reimbursement mechanisms that provide for these integrated, coordinated models that are neutral to the enabling technologies, particularly with regards to telehealth, are critical to going after these seemingly intractable challenges. And as WellSky, we see also just a really critical role for coordination across these in enabling coordinated protocols across these settings of care. And so a lot of our advocacy is how to create a national reimbursement framework to support home and community-based care, and it's neutral to telehealth, because we think that's the key to unlocking patient outcomes and lowering costs in these most vulnerable populations and those with chronic conditions and social determinants that are impacting their health.
Thank you, Jeff. Mike?
Yeah, so specifically as it relates to telehealth and technology, I think there's 3 different buckets to look at. One, the needs of the care recipient. There have been a lot of states that have sent, tablets and things into nursing homes or into care facilities and things like that. But you're typically care recipients in those settings are maybe dealing with some sort of cognitive decline, things like that. They may not be able to use the technology in the way that they need. There needs to be some sort of, assistance, some sort of accompaniment that goes along with that to make sure that it's not just putting a tablet in somebody's hand, but also making sure that they're getting some sort of effective use out of it. Looking at the needs of the caregiver, don't replace telehealth and technology with face-to-face interaction. Caregivers are often, feel isolated themselves. This has been mentioned a few times. And also making sure that they actually can be able to receive services via telehealth, whether it be some support counseling, something like that, receiving information on how to provide the care that they need to give. And then also thinking about the needs of the direct care workforce. Are they able to be reimbursed for, being able to provide telehealth services? There are so many situations where we see that service providers actually don't even offer telehealth options. So this is something that just needs to be expanded much more. And thinking more broadly, the way that we need to think about this is investing in the support infrastructure for caregivers across the country. Not only are caregivers the backbone for people with long-term care conditions, but caregiving really is the core to the nation's public health. Think about them as the family caregiver, as the string that attaches all the different components that address social determinants of health. They can really be, leveraged a lot more than we are currently doing. And then thinking differently about how we reimburse for services provided to caregivers. We need to incentivize providers to view the caregiver as recipient of services, not only to improve the health of those they're caring for, but also to ensure that they don't suffer their own deteriorating health effects. There's a lot that we can learn from what's been done sort of within the VA program and within the aging network. but we need to expand our understanding of where caregivers are entering into the healthcare system, where we can be providing those assessments, asking them what it is that they need to be, not only to care for the person they're caring for, but to care for themselves. And this technical assistance can be provided from the federal level, with service delivery taking place in the local level.
Great, thank you. And Dorothy?
Yeah, and I would just add to that, it's really the emphasis on the practical approach to this, which is, many times people will say, well, that area has access to broadband, but if nobody can afford it, or if a large segment of the population in that area can't afford it. So access and affordability have to be tied together. Is there broadband there, and do the individuals who really need it have access to it? And then I'm echoing Mike's point about you can't just put technology in people's hands. That support system has to be there to make the use of that really possible. And we need to do that across caregiving as well as patients. Some patients want to access the technology themselves and are capable of doing that. Where they cannot, the caregivers are really the important link to that. And when I think about equity also, we think about, and I think Mike echoed this point as well, which is we want to make sure that people have access to face-to-face care where it's needed or where they really prefer it. You don't want to create a situation where some folks only have access to telehealth delivery of care, because sometimes a direct service or a direct care provision is needed, and we want to make sure that equity is there as well. So those are the points I would pull out, because I feel like Mike did give an overview of the caregiving issues quite comprehensively.
That sounds great. No, I really appreciate all of your responses, particularly when we think about vulnerable Americans and whether it's low income or low literacy levels, rural or urban communities of color, and understanding how we make sure that all segments of the population can benefit from these services. So really appreciate that. We have many questions, thank you to the audience, up in the queue. And I'm going to combine a couple of the questions and actually go through 5 or 6, so you have a little bit of time to think through your responses. And again, any of you can respond to these questions, but I'll try to gear them towards each of you in particular. Nancy, there are several questions related to telehealth. One question focused on what happens after the pandemic is over and it's safe to go back to face-to-face visits. Do you think that we'll continue to have so many visits going towards telehealth, or will we go back to the small numbers before? There's a second question also, Nancy, about when we talk about telehealth, there are lots of modalities. There's telemedicine, there's remote monitoring, there's telehealth, so you can assess the home environment. Which of these do we think that patients are benefiting from the most, or where there's high patient satisfaction? So a couple of questions there. Jeff, there's a question on, do you think COVID-19 will accelerate the hospital at home concept? I think I know what your answer, but that's one for you. And then Mike and Dorothy, a couple of questions related to caregivers. Are there lessons we can learn from European models of healthcare to improve the US caregiver experience? And then a question related to the care delivery team, nurses and caregivers. Are there opportunities to support payment for nurses to assist the caregiver in learning their role as a caregiver? So a couple of questions on a variety of topics, and maybe we'll just take it in that order. Nancy, if you want to start with some of the telehealth related questions.
Sure. And I think I wrote them by, you might need to remind me of some of them.
Sure. Sure.
So I think the first one was about, how much or what happens when we go back to the safety, that it's safe to go back. Do we think the numbers will go down? I think it will just change. I'm not so sure it will be all face-to-face necessarily. I think that was the second half of the question, or the second part of it was there's lots of different tele-whatevers, right? And I think, the first one from a long time ago was a store and forward teleradiology. And so I think quite a few of those particular specialties will a bigger portion of their business will stay in a telehealth manner. It doesn't necessarily have to be face-to-face, but I do think, and we've all mentioned this, but the origin of that connection is going to need to be as broad as it is now. And some of the, so have we go back, remote patient monitoring with telehealth, that has seen an uptick, and I think that will continue to see an uptick because we can now, not only that we're keeping them away from the facilities, but they're just healthier at home, or being able to move around in their home or in their neighborhoods and still not have to access the hospital systems. Did I get them all?
Yeah, I know. I think so. Yeah, and I
Okay.
think home monitoring was also a question
Yes.
yeah.
Yeah, so home monitoring has seen an increase, and I think it will continue to see an increase because there was a lot of skepticism, and does it really working, and does it work? And I think we've proven that patients like it. There's all kinds of stats, and I think Dorothy brought some of them up, that especially in the aging community with comorbidities, we can better monitor, and they feel actually like they're better taken care of because they see they have people outreaching to them. So I don't think that that's going to go down.
Okay, great. Thank you so much.
Sure.
Jeff, you want to take the hospital at home question? You might be on mute. Sorry, Jeff.
I apologize. In both hospital at home and SNF at home, certainly COVID-19 has acted as a catalyst. And when you look at the places where we saw the need to relieve hospital capacity, for instance, in New York, in those geographies, Mount Sinai and other health systems moved immediately to free up hospital beds, and the organizations have been focusing on that for many years. I think about the private organizations like Contessa, and then all the leading work that's been done out of Johns Hopkins, immediately called upon for insight and answers to help accelerate those models. We're seeing a similar impact on SNF at home. So ubiquitously among the home healthcare, particularly the larger home health enterprises that we support, ubiquitously getting pulled into SNF at home, driven by patient safety, patient demand, and also health systems looking at SNF diversion, SNF avoidance. And those trends are likely here to stay, because in many cases it's almost very often what patients want. And then there are long-term cost drivers as well that support these models.
Great. Thank you, Jeff. Mike and Dorothy, do you want to respond to the caregiving questions?
Yeah, one of the things actually just that jumped most immediately to mind as we were thinking about European models is how they are actually formalizing bringing caregivers into healthcare settings. This is a little bit different than the technology piece, but when COVID-19 first hit, there was just no appetite in the US for family members to be coming into healthcare settings. But one thing that we actually saw that was led in the UK and is now being adopted by in certain states is that there is like sort of a credentialing system where, you know, a very formal process where a specific family member, usually we call them the primary caregiver, is identified. They are sort of logged into the system. They're given some sort of badge. They are, you know, given the proper PPE equipment that they would be needing, and they're also, you know, tested and things like that to be sure that they aren't bringing the virus into the settings. You know, this is something that's allowing families to actually come back together a little bit more, and it's something that we you know, saw being led in the UK and now being adopted by more states. And then the other question about you know, who could be working with caregivers more and being reimbursed to do so. I know nurses were specifically brought up, but it also comes to mind physicians assistants, home health aides, and social workers could also be, you know, really tapped to be much more supportive than they currently are.
Great.
I would add to that. I think, you know, the UK has a minister for isolation, which they have really elevated that priority and looked at what isolation does to people's health. So I think that's a model that has been looked to by various countries in terms of what is the impact of isolation. And you've seen AARP's work around that, and there continues to be concern and the need to going forward to talk about what breaking isolation means going forward, and how do we do that, whether it's through whatever care setting we're in and however the care delivery is being provided. And again, caregivers are a huge part of the network that supports the patient receiving care. So supporting caregivers and doing all of that is tied in with that as well. The other thing that comes to mind is I think in Europe, and AARP has an international department that specifically looks for lessons around these issues, a broad issue of the aging agenda and what are international examples. But the communities there have done some really interesting things in the Netherlands and other places around bringing college students to live in retirement communities. And these are interventions aimed at ending isolation, but also have the byproduct of helping the college student pay their rent, because they give them reduced rent for having for where they are living in exchange for engaging with the folks living there, older people. So I think we do see some interesting models that as we go forward and try to emerge from this pandemic, are there new approaches that we should integrate and try and build into these systems. Particularly, we are very focused on what's happening in nursing homes and how do we look at that model going forward to ensure that not only are people's health protected, but as they go forward and get care in whatever setting they are, that the isolation is really addressed.
Great, Dorothy, thank you so much. Nancy, there's one final question that's come in focused on the satisfaction of providers as they practice telemedicine. And is there any initial data, particularly since COVID-19, about provider satisfaction and the quality of care that they're providing?
That's a great question, because their world in some cases has turned completely upside down. And although I don't have a specific stat, maybe some of the other panelists might have a specific stat in provider satisfaction. All I have is anecdotal, which is those that embrace technology to start had no hiccup at all. And those that didn't embrace the technology in their regular practices had a very high percentage of dissatisfaction. So I don't have an overall satisfaction. I don't know, Jeff or Dorothy or Mike, do you guys have any stats? I don't have one, I apologize. No, doesn't look like it.
No statistic, but the point certainly.
Okay. Great. Well, we just have maybe 2 or 3 minutes left, and I want to give each of you an opportunity, maybe 30 seconds or so. If there's one final point you'd like to leave with the audience. I think we've covered quite a bit of ground, and I want to thank all of you. But we can go down the list, particularly I think from a patient perspective, patient-centered perspective. That's why we're all here, trying to help patients and family members. And what's sort of the one last point that you'd like to leave with the audience?
Well, I can start. I think from the point of view of the American Telemedicine Association, it's really, especially in with patients and clinical and non-clinical caregivers, is to focus on supporting the state and local initiatives that are going on to eliminate the barriers and continue to kind of cement the gains that we've had during this time frame.
Great.
And I think if I was going to close with a point just a little bit, I would think about the role of caregivers and these personnel in some of the critical needs for contact tracing, case investigation, and wraparound social support. Right now, by all signs, the entire nation is really struggling here, and there aren't that many programs that you can point to that are truly integrating each of these elements, along with ideally some elements of remote monitoring for diagnosed cases. And so I think there's a tremendous role for caregivers, and telehealth is a necessary part as part of contact tracing, case investigation, and wraparound social support.
Great. Thank you, Jeff, for raising that. Mike?
Yeah, really the big takeaway is to think about caregiving more broad than just an issue where people are caring for aging parents. That's where a lot of the investment has been done, especially supporting caregivers on the federal level. But there are a lot of caregivers caring for younger people with serious conditions, all the way from the time that they were born on through. This is something that we can. There are cancer caregivers that are sort of don't fall into that aging bracket and things. This is more of a public health issue that I think that we can be looking at a little bit more deeply. The CDC has really been able to lead the way a lot in terms of defining caregiving in terms of public health, and how to really specifically look at the effects that are taking place to not only the financial security of caregivers, but also their health and well-being.
Great, thank you.
Yeah, and I'll just close with picking up on that comment. It's really when people think about caregiving, they often do think about caregiving to the older population. But where we've had some really interesting research and work on is really often people assume the caregiver is an older woman or a woman in her middle age. And we've seen men in caregiving, we've seen millennials in caregiving, and we've had conversations across these populations that really reveal these are family problems, and that lessons learned in caring for an older person bring lots of insight and lessons across all the caregiver ages that are doing it, but also insights to the different populations being cared for. So as our crisis continues and we continue to need caregivers, learning from the lessons that we already have, but drawing from this new environment, how do we continue to support family caregivers who are caring for anyone and bring those insights across all the populations?
That's great, Dorothy. Well, I want to thank all four of you, Nancy, Jeff, Mike, and Dorothy, for your leadership, your expertise, all these insights. I want to thank the audience for their excellent questions as well. That concludes our panel. To the audience, please tune back into the same page at 2 o'clock for an Executive Insights interview with Jenny Bryant from Pharma. But once again, thank you again for this terrific panel. We covered quite a bit of ground, and that wraps up today's panel. Thank you.